Trust who are with us today. We know most of the faces, so very welcome to you as well. We'll kick off straight away with apologies. We obviously have quite a few apologies today, because if you look around, there's not too many here. We have some councillors online, but we have apologies from Councillor Earl Thompson, Councillor Stephen McCann that we know of. So I'll check with the group leaders. Councillor Coyle, is there any apologies, other apologies from your party?
No, Chair, I'm not aware of any.
Okay. And there's nobody else here to ask, so we'll move on. Alison is running a bit late. She was coming back from London this morning, so she's running a wee bit late. To sign the minutes of the previous meeting, that's already been done. Any declarations of interest out there? No. And we'll go then to item number 4, which is matters arising. And we'll go through the minutes of the last meeting. Page 1. Page 2, page 3, and page 4. Okay.
Chair, the action under 5.3 has been actioned by the trust. It's on the back page.
5.3.
Yeah, in response to a query from a member, the Director of Occupational Care agreed to provide a breakdown of the 110 graduate posts by location, Baltnagalvan, Southwest Acute and Omagh Hospital, and the detail was sent in the e-brief.
Thank you. Thank you. That's it. We will move on then to item number 5, and that's to receive a presentation from a representative of Southwest GP Federation regarding the works of GPs in council areas.
Hello, my name's Rachel Wright. I'm a GP in Lisnaskea, and I'm the chair of the Southwest GP Federation. I also have Margaret Cunningham here with me, who's the deputy manager of the Southwest GP Federation. So I've just got a very, very brief presentation. I'm going to introduce you to the Federation. Oh, sorry. I'll sit down. I'm going to introduce you to the Federation, what we do. I'm going to run through the challenges facing general practice, primarily focusing on access because that's the bit that everyone's interested in. But more, I want to focus on how I feel that the council can help us as a federation, us as primary care. So the Federation is, it came into being nearly 10 years ago in 2015. There's 17 federations across Northern Ireland, and this federation, the Southwest GP Federation, covers the Fermanagh and Omagh council area. It is made up, it's a community interest company, not for profit. It is made up by one GP from every practice in each of the 20 practices across the area, who each have an equal say in federation matters. Our first big project was 2017, embedding pharmacists into each general practice. They're a huge help, and that's been well embedded by now. 2018-19, we got some premises, we started to get some staff, and we had this transformational money that came in that practices are spending in different innovative ways to try and improve access, such as locum GPs, administration, and developing the earliest bits of an MDT with physios and mental health workers. Moving forward into 2020, 2021, we further developed our team. We moved to new premises, which are just around the corner from here. COVID-19, of course, came along, and we were heavily involved in the COVID centres to develop a separate COVID positive stream from general practice, but never stopped seeing people. And then the general practice nursing stream came on toward 2021, which this was a project showing that we don't have enough general practice nurses. Many nurses are reaching a retirement age, but there wasn't a programme to train nurses into primary care. So the Federation ran a programme to embed currently 6 nurses in different practices. 22-23, we now have 38 staff. A lot of work on governance and developing lots of different policies, and also an advanced nurse practitioner programme where we have 4 nurses trained through the Federation and embedded in practices. And then moving forward, looking to the future, we've got our strategic plan. We're keen to listen to the local needs and develop depending on what is needed in the local area. We're running job fairs and basically supporting the practices. So, as I said, we've got the general practice pharmacists. We've got 20 of them in practices. We've got 4 nurse practitioners, 6 general practice nurses. We run an education programme for both clinical and non-clinical staff. The skill mix funding, the GPES services locally, there is women's health in Lisnaskea, there is dermatology in Omagh and Castlederg, and there is minor surgery in Omagh, and we're hoping to bring on vasectomy in the near future. So coming on to access. Access, of course, is the hot topic. You can't get through. Why can't you get through? There is a huge demand. My own practice had roughly 5,000 calls on a Monday morning out of 15,000 patients. And so then, you know, we could increase phone lines. Phone line costs roughly £500-ish per line per year. But again, unless you've got someone to answer the phone line, it doesn't move the journey on for the patient. And so receptionists are the key first point of contact in practices, and they're working for minimum wage and getting an awful lot of flack about the access side of things. They're getting told at least once a week, if I die, it's your fault. And then they're leaving, they're working for the same money, for the same minimum wage in places like Tesco and Next and coffee shops where they're not getting the same amount of flack. So say you do manage to get through, you do manage to talk to receptionists, then it's, I can't see my doctor. Now I'm going to come on in a minute to some statistics to explain why, but the fundamental problem is there's not enough doctors in Fermanagh and Omagh. And the third strand is I can't get sorted. Now, an awful lot is sorted in primary care. In fact, statistics show that 90% of the work is done in primary care, but often we need secondary care. And I'm sure everyone's well aware of the issues there. But in support, that the impact of things like waiting lists, which I'm sure everyone's well versed in, does have a knock-on effect to primary care, because the only place they can come back to while they're waiting is into primary care, and that then is an increase in demand. So say sharing with you some statistics. I'm not sure how much you can read them, but the Fermanagh, the South West Federation has 20 practices. Currently 16 are in traditional partnerships. 1 is run by CIC and 3 are trust run. We cover a patient population of just under 130,000 and a massive geographic area. We're the biggest geographic area federation across Northern Ireland. We currently have 69 GPs as of the BSO statistics for June 24. But that is a drop from 80 the year before. So we have lost 13.8% of our GP workforce. And this ranks bottom across all the 17 federations. And so that, I think, underlines why it is so difficult to see your doctor. That translates to a ratio of 1 GP to just over 1,800 patients, or 53.46 GPs to 100,000 patients, which compares with the Northern Ireland average of 70 GPs to 100,000 patients. So we can see that we just don't have enough GPs in the Fermanagh and Omagh area, and that translates into what I'm sure you hear as council all the time of why you can't see your doctor. And the other bit to share with you is the percentage of GPs over 55 is 35%. So GPs on, by and large, their retirement age is around 60. Many do stay longer, but the way the pension's set up for that cohort, most would be looking at retirement around 60. So it shows that things are, unless we can attract in an awful lot more, things are going to get worse rather than better in the next 5 years if a third of the workforce is of retirement age. So the challenges are, how do we recruit staff? How do we retain the staff we have? GPs, other clinicians, nurses, administration, reception. As I say, we have an ageing GP population as well as an ageing patient population. And we have many practices that are seeking support from the crisis team. So the crisis team steps in whenever a practice is getting to the point of saying, I can no longer go on. And indeed, 4 practices in this area have handed back their contracts over the last 2 years. So I don't want it to be doom and gloom. I'm coming to think, well, how can the Health Committee help primary care? How can they help the Federation? And I have 3 simple asks. One is support. It's easy to fall into the narrative of everything was fine before COVID, GPs are all sitting remotely, we're not doing anything, it's all doom and gloom and rubbish, whereas we're working harder than ever. And feeding into that narrative then just creates a more negativity, and a lot of people are quiet quitting. They're reducing hours, they're stepping back, they're looking at alternate careers, and that's right across reception, nurses, doctors, and we're losing people that we desperately need. And so support is what we're asking for, explaining that it is not that we're sitting doing nothing, but just that there's not enough people, that there is a process to get an appointment, and that will involve the receptionist asking why they're looking for the appointment, and that is mainly to signpost patients to the right person at the right time. We're also looking for your support on funding. Now, I know the council doesn't control the health budget, but you have the ear of people that do. It's widely known that primary care gets 5.4% of the health budget for 95% of the contacts. And so everyone's saying this needs to increase. Minister Nesbitt came to the LMC conference and he asked, you know, if you had an extra 1% or an extra 2%, what could you do with it? And there's an awful lot we could do with it. But the uncomfortable truth is that in 2019, with 10% of the health budget, now with 5%, that's part of the reason why it is so bad. And the first 1 to 2% is probably just going to be for stabilisation of services. So not massive changes, not massive wins, but keeping the lights on, paying the DDRB, paying the national insurance uplift. And then we can begin to look at, you know, we want to pay, if we could pay more than minimum wage to receptionists who frankly deserve more than minimum wage, then we would be strengthening the whole process. We'd be retaining who we've got, and then we can look at the next 7, 8, 9% at what services can be delivered in addition. And then the third strand is service enhancement. So there's been a lot, I'm sure you've heard about MDTs, and hopefully they are finally coming. But but it's getting behind it. We also have this work that I've said about AMPs and GPNs, but we've only got 4 AMPs and 6 GPNs. Last time we went out to recruit, we could have recruited 5 times over. People want to work in primary care, but the funding isn't there for us to continue growing that workforce. So thank you very much for having us here today. We're here if there's any questions. Thank you.
Thank you very much for that, Rachel. A lot of what you said for the councillors that are on and are online, we certainly can recognise what you're saying to us, because we hear it all the time. I'm going to take questions now. My system isn't working here, so the first up is Councillor Barton. So if you want to just go ahead, because the system isn't working. I can't. Right, I'll try it again here. Move that out of the road. Oh, there we go.
Thanks, Victor. Thank you. And can I thank you very much for your presentation. I'm new onto this committee again, though I have had my finger in politics for some time, but was out for a year or so. So this is new and interesting news for me. One of the things you mentioned, the reduction in GPs from 80 to 69 GPs. You're telling me the 69 GPs throughout the Fermanagh and Omagh Council area, there are only 69. As a follow-on from that, can I ask, are those full-time, and what exactly is a full-time GP? Excuse my ignorance in asking that question, but are those 69 full-time or part-time, or is it the equivalent of 69 full GPs you speak of?
I think it is 69 GPs in total. So I don't know the equivalent, whole-time equivalent. Now, most GPs with the pressure of work 3 to 4 days.
Yeah.
Now, these days are usually 12 hours. So whenever we're talking a 3-day GP, you're still talking probably 36 hours, which is getting on for what most people would call full-time of 37.5 hours. And then additionally to that, because there are very few, with the changes in the way GPs work, they're really, I'm not aware of any that are doing the 10 sessions a week, 5 days, but it's not that we've 2 days off. We've got, say, involvement in federation, involvement in the GPES services, involvement in appraisal. So a lot of GPs are developing what's called a portfolio career. So they might do 3 days in practice and 2 days doing something else within the medical sphere, such as this federation work for myself.
Right. So forgive me for being ignorant of this situation. So therefore, for most GPs, I use the word roughly, for most GPs, they're involved in their practice for 3 days. So therefore, really, there are 2 days when locums have to come in to complete that week. Is that what you're saying to me?
It wouldn't be locums. There's very few locums in Fermanagh, but for example, myself, I work 4 days.
Yeah.
And I'm not in the practice on Tuesday, but I'm generally then wearing a federation hat and doing federation work on a Tuesday. And so the practices are set up so there's not a day where there'd be no GP. But, you know, while I'm not in on a Tuesday, I've got 3 colleagues that are in on a Tuesday. So throughout the week, throughout the 5 days, there will be a GP cover. And then, of course, there's out of hours cover that provides the service from 6:30 till 8 through Western Urgent Care. And a lot of the GPs that are doing the in-hours work are then going to out of hours. And so working, say, from midnight to 8, then coming in, doing a day in the surgery. And that's difficult to sustain. So it's the same pool trying to do the same bits.
Yes, I understand about long hours. I had them too in my career, so I'm aware of a 14, 15-hour day. I understand that. But the problem is GPs out of our surgery, there are constant complaints about this, about that. There are no GPs on call, no GPs, etc. And I'm sure you're very aware of it too. And therefore, people, instead of going to their GP and call, they're obviously transferring to the hospitals, which I know you have no control over or anything, but to A&E or emergency departments there, and it's a whole merry-go-round. So I do understand that. The second thing I want to ask you about are receptionists. I understand, and I can understand the flack. I understand that receptions take a lot of flack now because of problems getting through to a service. But can I say that from outside perspective, looking in, you phone today to look for an appointment and you're told after making 50 phone calls, sorry, appointments are gone for today. Phone back tomorrow at 8:30, 9 o'clock. You phone back tomorrow at 8:30. You make another 50 or 60 calls. Sorry, appointments are gone. You phone back the next day. Can you
Totally
not
get the frustration.
understand? And my concern is, as a counsellor for constituencies, that there are constituents. I use the word elderly constituents particularly. They just cannot keep standing in a hallway or wherever their phone is if they don't have one of those ones that you can lift and walk about with, especially the more elderly, that they're making phone call after phone call and getting nowhere.
And as a
And
GP,
that-
I find that really difficult.
You
as
find
well.
that difficult, and I can understand why people are cross with receptionists, but I don't accept, you can't be cross with them. It's not their fault either, but it's an issue that there seems to be no answer to. And I think that's something
I think
we need to be looking at in relation to that, because I know in the area I live in, to get an appointment, people are actually walking into the practice to get an appointment, and that should not be the way.
I totally agree. The difficulty is, as a GP, I can only see one person at a time, and there needs to be more of me. And that's what I'm sort of thinking. The way that there's going to be more of me is through retaining the people that are here, but also attracting people to this area. And it is the most under-doctored area. There are various streams such as Attract, Recruit, Retain from the Royal College GPs, but it's a Northern Ireland-wide strategy. And I feel that as an area that's really struggling, everywhere it'll say they're struggling, but we're really struggling, maybe consideration of golden handshakes, trying to attract people, because at the minute, if I were a young GP thinking, where am I going to put down roots? You're going to earn roughly the same everywhere. Am I going to work in a practice with 15 other doctors? I definitely get my leave. It's all quite comfortable. Or am I going to come to the West where there aren't enough of us? And also thinking, this is going to get worse because my colleagues, 3 of them are over 55, and this is going to get more difficult. So it's that I don't have the answer, but I think we need to really look at strategies to particularly attract GPs to under-doctored areas. So things like the Highlands of Scotland had similar issues, and they did have golden handshakes, and they did manage to get some people in to services that were falling apart.
This is my last one. So as to
I suppose ultimately everything flows from SPPG, that flows then from the department, flows into SPPG, who then determine where the money is spent and where it goes. As I say, this strategy is there. but it's whether we can actually try and get it westised to attract people, particularly to this area. Because I agree, I feel for particularly the elderly, but I can't see more than one person at a time, and that I can't be in two places at once. The other side is developing who else can see the patients, and that's where the MDT will be, the multidisciplinary team. So this would be that if you have a mental health problem, probably best to see the mental health worker. If you have twisted your knee playing football last night and it's not an acute injury that you're going to A&E about, then seeing the practice physio is going to be better than queuing up to see the GP. So we probably also need to change the narrative, because a lot of people, everything focuses into got to see the GP, whereas actually it could be see the practice team. Because as I say, whenever we went out for nurse practitioners, we could have filled those posts 5 over. So they can definitely, they're not the same as a GP, but they can do an awful lot. They could improve access, but we need to change the narrative of you can't see my GP to see the primary care team, which I think is probably a quicker win, but we still need more GPs.
Okay, we'll move on.
Thank you.
We've other speakers here. Anne-Marie.
Yes, thanks, chairs, and thank you very much, ladies, for coming along in the presentation. I did miss the first couple of minutes, and I suppose I'm declaring interest. I work with NIAS, and also see the huge difficulties with not being able to get the GP and queuing up at A&E. I know that I had wrote a letter, a few questions, so I'll maybe hopefully get an answer back today on some of them. But do you know what? And I know that you were saying that, you know, GPs work hard, you know what I mean, and everybody's working hard, but every healthcare professional at the moment, we're just getting hammered. Even from our own selves, I think that the high uptake of calls for the ambulance service to NIAS, and I'm not speaking on behalf of them, I'm not, but whenever just chatting to other colleagues, it's failure unable to get the GP. And you know what, it's for very minor ailments, it is for very, very, very minor things, that they're just genuinely small issues. And, you know, and that takes up about an hour and a half, you know what I mean? And then even for the access from the A&E service, NIAS, trying to get in contact with a GP or receptionist, we have to join the queue as well. So therefore, sometimes at the house, we have to wait, you know, 2 or 3 years on the phone back from night, and that's taking an A&E motor off the road, sitting in somebody's house just to get a small prescription or something, you know. And I know there's nothing you can do about that, but this has huge implications on everybody else. And it's sad that people isn't taking up the jobs in areas, and I'm not very much one for a golden handshake. I really am not. I'm against it. But maybe this is a situation that can be looked up in this area. Another issue as well that I suppose we're talking about receptions, they are very badly paid. And I feel sorry for the girls because it is a really low wage that they are on. And I think that is something that should be looked at as well. A lot of people are getting concerned because they're asking private personal questions, you know what I mean, from people looking to see a doctor, and people saying to me, or even, you know what I mean, what's this, you know what I mean, is it not personal, is it not GDPR, you know what I mean, like we're telling people who are not qualified just about health concerns, so they also have issues with that. Another one is that even a simple thing is answering the phone, you know what I mean, I answer the phone because, you know, elderly relatives myself, you know, you could be on from 10 to 9 in the morning and you just leave it constantly ringing for 40 minutes, you know what I mean, and I know people doing that there, at least to answer the phone. You might be booked up, you know what I mean, but I've yet to get a phone call, or if somebody can answer the phone and say, sorry, we're booked up, try the next day, what is it, you know what I mean, well, you can get a prescription from, have you tried your chemist to get a prescription for a UTA, you know what I mean, there's simple things, but answer the phone and under God for me, you know what I mean, I think that's one of the simplest things that can be done, answer the phone and chat to people, because non-answered phone calls is really, really impacting and making people more agitated. I'm really, very strong in case with that there. Patients are going, like we all know, they're going till A&E and ringing 99 calls, but A&E is not the place for them either, because especially at McGalvin or Craigavon, because this isn't an issue for you, but they're queuing up on wheelchairs and corridors and they're freezing there for hours, you know, on end. And an issue there with McGalvin as well, but I'll come on to that later on. I was just wondering just about the receptionist. You were saying earlier on about signposting, receptionists being able to signpost, and I know that I've said there before just about GDPR, but are they the skill levels necessary to signpost people onwards? And I'm on about the primary care team or the multidisciplinary care team. Is there times I sort of heard back, but I didn't want to really pursue it because I just thought, no, that's wrong. There is areas where there is trained paramedics, you know, and are they I don't want to say too much, but I think there might have been on occasions where they were just on duty themselves, and so they asked to cover them in a particular practice during the day or whatever, just for not getting into that, because I don't know whether to believe that, but maybe that might be the case. Maybe the GP does ring in your room or something and they might do just the genuine calls. And I think that's what it is. But I think from the start, they're getting a lot of black receptionists. I know one girl particularly well, and they do get a lot of practice. But I keep saying to her, at least answer the phone, you know, and answer the phone, because that's all the people really, really want. Answer the phone, you know what I mean? And you might get a bollocking, but the vast majority that you won't, you know what I mean? But that's the best practice. But I know your job's very difficult. And an elderly population is climbing, and there's an awful lot of, you know what I mean? But for those small, simple diseases, you know, it can be treated just by antibiotics. But that's mine, just, you know.
Thank you, Anne-Marie.
Maybe if I could respond to that. I mean, in terms of answer the phone, the difficulty is receptionists are constantly on the phone. As I say, my own practice has got 15,000 patients. We had 5,000 calls on Monday morning, which is a third of the practice population. The stats show that half the practice population are trying to contact their GP every week. So there's a huge demand. As I say, to answer the phones, I'd need 5,000 lines. That's £500,000 for the practice. That blows the budget. You know, and then I'd need 500,000. I'd need 5,000 receptionists to be able to answer each of those calls. And I know it's not at that level, but you know, we have 10 receptionists constantly on the phones taking the calls. But same as a GP, I can only see one person at a time. A receptionist can only see one person at a time. And so they are answering the phones.
Sorry, I want to interject there. There was only a couple of lines that the lines engaged, and then you automatically get on, and you sit in 40 minutes, and only is 3 or 4 lines of the particular surgery, you know what I mean, that I'm talking about. So they don't answer the phones. They don't answer the phones because there's only 3 or 4, you know what I mean, lines. I would have somebody ask the phone beside me and say, no, the phone's it's engaged, my phone's engaged, but you're through, so ring away. So you know what I mean? So they genuinely don't answer the phone. But that's just basically, you know what I mean? I we're going to beg to differ in this one, so I'm happy enough for that.
You were also asking about the queuing. Now, offline, we can have a discussion. I've shared all practices do have a health professional bypass number. And we'd certainly shared ours with NIAS, which is a way that health professionals such as NIAS, such as district nurses, can come round the queue, because I agree, it's, you know, we're all busy people, and it is reasonable for health professionals to have a bypass, and all practices do have some sort of bypass line. There's probably a bit of work to be done on how to communicate that to all services, but it should be there. And then,
Yeah.
We'll move on.
Thanks.
Sorry, Debbie.
Thanks, Chair. Well, I suppose some of the questions I was going to ask around GP, sorry, and locums and all them kind of things have been asked. But it does seem to me, I have to say, actually, my own GP surgery, I wouldn't have too many complaints about now, to be fair, that on a personal level. But as a councillor and working with the local MLA, it is absolutely just constant. And I suppose I need to declare an interest, Chair, actually, because I work in SWA. And so when you go down to A&E, especially on a Monday morning in particular, and like probably over half of the patients sitting there waiting have been referred there from a GP. I don't know, I've worked in A&E loads of times, so I'm not medically trained, so I'm not going to pass too much judgment. But it does seem to me that some people are probably better off seen in the surgery. And I know you're saying about time and all that, but there seems to be bad communication. That seems to be one of the main things, and one of the main things that we would get complaints about. And I think Anne-Marie's right. If you've got 5,000 people ringing, you don't need 5,000 lines. What you need is a few workers, and put on one of them waits that you're now 20 in the queue. If they want to hang up, they can hang up, but they can put the phone down, put the loudspeaker on, go and make a cup of tea, go and have a shower, whatever they want to do. By the time they've done all that, they'd probably be number 2 or 3. But at least they know they're getting an answer. And that's what happens so it's as frustrating as that might be, which isn't too bad, at least you're going to be answered. And I think that's a good way to do it. I just think so many people are sent to up to the hospital that probably really don't need to be there. And going back to reception, who pays the receptionist is one of the questions I want to ask, because I don't know if I've really got it's not a private business, so you're a community based and not for profit. So, but who actually pays the receptionist? Why are they on a minimum wage, and how can that be changed? And I think that if I ring up the doctor and the doctor says to me, are you phoning up, I don't mind saying, well, I've got maybe a chest infection, or I've got pain here, or I've got a headache, or whatever. But I don't think you should ever tell a receptionist anything more than that, because they aren't medically trained. And I certainly would never tell a receptionist anything more. If I had chest pain, I'll just say I've got chest pain, or I've got hay fever, or I've got cold, or whatever the situation, or fell, broke the ankle, whatever. But other than that, I would not be telling them anything else other than that. And I don't think they should actually be asking. They should actually be asking because the complaints that we get about it are just increasing all the time. And I do feel sorry. They are low-paid workers, and they should get more money, and they should have more respect from the general public a lot of the time. But they've also got to give it as well. And I do find that's one of the biggest complaints here, is that the receptionist would be asking too many questions, and then actually they still don't get the appointment. So it leaves people very, very frustrated. So I actually think, as well as funding and the issues that you've raised around, around support and stuff, and you do need support. I need support in my job. I'm a healthcare assistant, so like you, I can take loads of abuse as well, and have to on a regular basis. But I shouldn't. It's not part of my job to do that. But I think the funding, and the funding is an issue, but I do think communication is actually key to a lot of the complaints that we get. That lack of communication, and just that. I mean, I would imagine that you get a lot of reattenders, like people that phone every Monday morning. They're probably some of them would be the same people all the time. I don't know what kind of mechanism you're going to find for some of those people, but that I think needs to be kind of looked at, so that people with more emergencies can be dealt with. I think communication is key here, and I know people in the hospital that they've rung day after day after day, and they just cannot get through. So I think if everybody, some of the practices where there's a good practice, and I have to say my doctors in Enniskillen has that. I just can't complain about them at all. You ring up and your number, whatever. And at least you know you're getting answered. And if there was something like that or the same as that, where everybody knew that they was going to get answered at some point or another, and an appointment over the phone, appointment over the, like here on the computer, or an appointment in person. You know, I know it's really hard. I know there's a shortage of GPs, but I just think a little bit of work needs to be done around communication, because it's the biggest complaint that we get into the office here. Thank you.
Shirley?
Good afternoon, everyone, and thanks, Rachel, for engaging with us this afternoon. Probably I'm just really going to say a little bit of what other people have said here, but I agree wholeheartedly that the receptionist actually, there's many an ailment that you do not want to tell the receptionist. And I have had so many complaints from people who maybe work in a busy office. They do not want their colleagues sitting beside them to know what they're going to tell their GP when they go in there. So that is a huge problem, especially maybe a lady has a problem that she does not want male colleagues sitting around her to hear, and she has to explain that to a receptionist before she can get any further. And all she wants is her own doctor. She doesn't want to be diverted anywhere else. So that is something that definitely, from my point of view, needs to be looked at. The other thing that has brought to my attention a lot is in Omagh, for example, we have only 2 hours to ring a doctor. Great for people who's told to even ring back the next day. But in my particular surgery, you ring on a Thursday afternoon and it's 2 hours. And I have had elderly ladies come into my office, and I have personally sat 178 times before I got through for that lady. So it's not an easy thing to get through for elderly people to their surgery. Then on top of that, in Omagh in particular, you can't get an appointment at all. So there's a private practice in Campsie. You walk on it and your own doctor's sitting there. So I don't know. I'm sure a doctor does a full week in the practice. I'm not disputing anything about doctors, but he has time then to be sitting in a private practice where these, you know, where you're supposed to then pay, I think it's something like £60. I haven't been, so I just can't verify that. But I've had loads of complaints about it. I've had ladies who refuse to pay them because they were their own doctors. So there is a huge problem in the health service at the moment with GPs, and the morale with people is at an all-time low, and there is so many complaints, but we're not going to solve them this afternoon, so thank you for your time.
Okay, we'll keep moving. Finally, we have Colette. Hear me, Colette? Colette has left the building. Back, yeah. Go on ahead, Rachel.
Just wanted to reply to a couple of those points, and I think it's really eye-opening because whenever you're working in a service, you sort of understand it, but it's realizing that there is a lot of work to be done on communication, and even communication of who pays the receptionist. Now, what in a standard general practice, that is a small business, but the only person that puts money into the business as such is SPPG. You get roughly £110 per patient per year to provide everything. And that includes all the business running costs, the heat, the light, the power, the computers, the receptionists, the cleaners, all the equipment, everything you pay for in that £110, which is why things are so tight. Current funding is such that if a GP came to the practice tomorrow, I mightn't have the funds to actually take them on, even though we desperately need them. So that's where the funding side is. As you say, the private GP is getting £60 for one consultation, whereas for just less than 2 consultations, then GMS is doing everything for that patient, every prescription, every referral. They can be seen. Some patients won't need seen in that year. Some patients may have a lot of health needs and be seen 3 or 4 times a week. But it's the same funding by and large per patient per year. In terms of the point about receptionists asking questions, that is something I'll take on board, that there is a lot of communication there. Receptionists are trained. They all go to care navigation courses and signposting courses. They're not medically trained, but they have got a code of conduct. They have a code of confidentiality that information won't be shared with anyone else. And the sole reason is to try and make sure that that patient's needs are met by the right person at the right time. So there are a lot of other services that have been developed. For example, there's a tonsillitis project starting where patients can be signposted to their pharmacist with certain criteria. The pharmacist can take a swab, the pharmacist can provide antibiotics. That person doesn't need to see the GP with their tonsillitis. But if the receptionist wasn't able to get the information that why they wanted to see the GP was because they thought the tonsillitis, then they take an appointment with the GP that could have been signposted to the pharmacist. Or a patient that has an acute red eye, there is funding into optometry services where that patient, instead of seeing the GP, can go and see the optician that day. There's funding and there's pathways with that acute red eye, see the optician, have a full eye exam and get sorted by the optician. So it's not the receptionist kind of being nosy or trying to block an appointment, but instead navigating to say, do you need to see the GP? Or could you say if it's a mental health problem, the mental health worker in the practice, the physio in the practice. But unless we know why the person is seeking health care, then all paths lead to the GP. And as we've said, there's not enough GPs to see everyone that wants to see a GP. And there are some very well-trained alternative clinicians that can meet some of that need. But unless the receptionist knows not everything, but a brief outline of why that person is wanting to see the GP, then they all get stuck in the bottleneck of waiting to see the GP instead of maybe seeing the pharmacist or the optician. I think that was all the points that were raised to us. But yes, there's a bit of work to be done on communication. And I thank you for the opportunity to come and try and
I have one more
explain
speaker,
things.
Rachel.
Yeah.
Colette, you had your hand up. Do you still want to contribute, Colette? There she is. Colette, do you want to ask a question?
Thanks, Chair. No, questions that I wanted answered were already asked as well, and it was regarding the phone line. It is impossible to get through, and I agree with Anne-Marie. Just answer the phone. People are beginning to have mental health issues. They might have rang in with other health issues, but they end up coming off the phone with mental health issues. It's a system that I have been told this year that doesn't work. I've been told about the phone lines in Dromore Surgery being the phone number being the wrong number, but it's simply not good enough. I don't think that you'd need to employ 5,000 receptionists to answer 5,000 calls. I think you're bound to be able to do something else other than that. To hire 5,000 receptionists would be great, but I don't know. We're very frustrated. We're extremely frustrated on the phone line. It just simply isn't good enough. That's all I wanted to say about that. Thank you.
Okay, thank you, Colette. Well, I think, Rachel, it's fair to say you are going to go away today with your ears buzzing and with quite a few different complexities to answer. And certainly I think they've nearly all been hit on the head today. And not all, as Debbie said, not all surgeries are getting complaints. but I certainly know as a councillor in Aaron East, which includes your area, we get a lot of complaints. So thank you very much for giving us your insight today, and hopefully we can maybe do something like this again in the future. So thank you very much for coming along today.
Thank you very much for the opportunity.
Okay, we will move on now to item number 6, and that is to receive updates from the Western Health and Social Care Trust. And the first item is an update presentation on overall activity for SWA and NOMA HPCC. Mark Gillespie, Director of Surgery and Paediatrics and Women's Health.
Sorry, Chair, just before Mark starts his presentation, could I suggest that we can quickly go through all our presentations and then take questions at the end?
That's fine.
Some of us have to be away by 4:30, if that's okay.
That's fine.
Just in the interest of time. Okay.
Okay.
Thanks, Mark.
Thank you, Chair. Chair, you'll be familiar, and council members will be familiar with the format of the presentation, and really what I'll be doing is an update today in terms of where we're at from a surgical perspective post the temporary change to emergency general surgery. For council members, one of the things that we were very keen to work through was ensuring that there was good public confidence around the emergency department at the point where that temporary change occurred in December 2022. And as you can see from the emergency department figures from April to October, the emergency department at South West Acute remains busy, and actually busier for this period, more busy this period than the last period. Admissions are only down slightly at this point.
Sorry, Mark, could you go a wee bit closer to your mic? We're having trouble hearing you.
1 wee second, and I'll just try to turn up the sound as well, Chair. Is that any better? Can you hear me?
I can hear you anyway. Online, you're loud and clear.
I think we've
Thank you.
lost him, Chair.
Yeah, I can hear you as well.
Mark, can you hear me?
Yes.
Can you
And
go on
every-
ahead? We can hear you now. Okay, thanks.
Okay, that's grand. Thank you. So just to go back, post the temporary change, one of the things that we wanted to ensure was that there was good public confidence in the emergency department. And as you can see, from April to October 23 to April to October 24, the numbers actually of emergency department attendances has increased. Admissions are only down slightly. We probably would have anticipated admissions being down a bit more given the change to emergency general surgery. But we are still busy from the point of view of admissions. And again, then consultant outpatients, which is only a small component of the total outpatients in South West Acute, remains busy. But again, all outpatients are at 62,000 and just over that. Go ahead, Chris. Obstetrics and gynecology, you'll also be aware, caused a degree of concern within the general public post the temporary change. And we keep dialogue very much open with the obstetrics and gynecology team. Live births are down year on year, but that is not unique to the Western Trust or indeed the Southern sector. That is something that we see across all of Northern Ireland. And just from a recruitment perspective, you'll know that we've been very focused on recruitment, particularly at consultant level. We have just had our final substantive appointment. Our appointee joined the team in South West Acute in September. So we are at full consultant numbers within the obstetrics and gynae team. Emergency surgical assessment data then. Emergency surgical assessment data has increased year on year since the temporary change. However, I see Professor Monica Monaghan on the phone as well. She will also have been at Strategic Development Group last week with myself and a number of other senior people from the Trust. And there was very good dialogue there from the point of view of GPs and how we can actually maybe enhance this service moving forward. Again, what we want to do through this service is minimise the impact on patients in terms of travel to Alton-le-Galvin where they don't need to travel. As part of some of the work that we're doing around emergency surgical assessment, we've also developed a standard operating procedure and policy where patients who attend the emergency department or indeed emergency surgical assessment, if they require a minor surgical procedure, we can book those patients into either South West Acute Hospital or OMA in the next 48 hours rather than have to make the journey to Alton-le-Galvin as well.
Mark, you've disappeared again. I don't know if you can hear me. But
I can hear you. I can hear you, Chair.
You disappeared there again. So go on ahead. I think.
Okay. So update on emergency general surgical services. We have been working and continuing to work with the emergency department consultants and surgeons to develop our guidance with respect to patients with surgical presentations. We've done significant work on gastrointestinal bleeding, head injury, testicular torsion, and surgical presentations. We've also developed a repatriation pathway, and that repatriation pathway is very important. Once patients come to the end of their acute surgical journey, that pathway allows us to repatriate patients back to South West Acute Hospital under the care of the acute physicians to have the remainder of their care in South West Acute. Again, minimising travel for patients and families. Minor operations, as I said earlier on there when I talked about surgical assessment, we now have a standing operating procedure where patients who present to surgical assessment or ED with a minor surgical presentation that requires surgery, we can book those patients into South West Acute within 48 hours and again prevent the need for travel to Alton-le-Galvin. We're also working with Professor Monica Monaghan on head injury patients, where those patients can be managed within South West Acute under the care of a physician moving forward. In the general public, we are very acutely aware of the concern around double waits or potentially going from emergency department to emergency department. And you'll know that we reset our system in May, and since that we've seen an improvement in terms of patients going directly to a bed in Alton-le-Galvin Hospital. And if Chris can just move to the next slide, you will see the improvement and the significant improvement that we've made with respect to that. Just to be very clear, there is a surgeon on call, 2 surgeons on call, generally speaking, in Alton-le-Galvin every day of the week. One is on for surgical assessment, the other is on for the take coming through the emergency department. Patients' allocations to bed are very much based on clinical priority and clinical need, and that is decided by the surgeon. But you can see, despite the challenge, we have made significant improvements in that particular area, and we remain very focused on that on a day-to-day basis. Developments then, we have been incrementally building the activity in South West Acute throughout 23 and 24 in alignment with recruitment and training activities, and SWA is now in a position to schedule commissioned activity. And I do want to pick up just on commissioned activity because there are a couple of numbers that are being used on social media and indeed some of the media outlets. When we talk about commissioned theatre sessions, the Department of Health traditionally commissioned services across 42 weeks of the year. However, we operate across 50 weeks of the year, generally speaking. So when we say 19 sessions, 19.5 sessions, that means 19.5 sessions across 42 weeks of the year. Systems don't line up like that. So when we operate across 50 weeks of the year, that will come down to 15.3 sessions. So that adjustment, and that's the reason why there are 2 different numbers. OMA Day Procedure Unit is now in a position to schedule its full commissioned activity as well. I already talked earlier on about the new gynae consultant, and we will have a full tier of general surgeons working trust-wide in the Western Trust by February of 2025. Those consultants are job planned with fixed sessions in South West Acute Hospital for operating and for outpatients as well. Tier 4 restructuring has been completed, and there will be a new lead for OMA DPC moving forward as well. Ophthalmology continues in OMA, and we are transforming our outpatient services in OMA as well, and we're moving some of what traditionally was used or seen in a theatre, like flexible cystoscopies, which is a urology procedure. We're moving them to outpatients again to create greater elective capacity for patients. Cancellations remain a concern for the Trust, but again, an area that we are very focused on in terms of getting some of the public's issues as to why this also occurs. Over the next 6 weeks, then, all commissioned activity is scheduled with operators and anaesthetists. This is a strengthened position from previous meetings. Inpatient and day case theatres are now providing general surgery, gynae surgery, colorectal surgery. ENT is commencing this month in Southwest Acute and breast surgery. So colorectal, benign colorectal will commence in Southwest Acute this month as well. If we look at activity then, from January 23 to December 23, we saw 2,921 patients had their procedures in Southwest Acute Hospital. And in January 24 to September 24, we have seen 3,100. So we are in line to overachieve from where we did last year in terms of activity. Thank you, Chairman.
Thank you, Chair. I'll just give a quick update on where we are with Better in terms of our planning in the on-schedule care directorate and across the Trust. So I'm sure everyone's aware, because you see the messages, that our pressures remain extreme, whilst attendances remain steady, with the exception of Southwest Acute Hospital, where they're up slightly over the last number of months. The number of patients who are awaiting admission on a daily basis each morning have increased, usually around 70 patients now at Galvin Hospital, any number between 65 to 70, with the highest, I suppose, in the last number of weeks as well at Southwest Acute for them, around 30 to 34 on a daily basis. The number of patients within our hospital services at this minute in time across both sites who are medically fit but remain there waiting for a discharge plan to be enacted has increased. And again, we're sitting with 65 to 70 on a daily basis in Altnagalvin and at Southwest Acute Hospital. And you're all very aware of all the reasons for that. So when I say extreme, I mean extreme and unprecedented in my experience as a director over the 12 years I've been a director in the Trust. In terms of preparing then for Christmas, New Year and on into the first quarter of 2025, we are now in the process of formulating our nursing and medical rotas across the Christmas holiday period to ensure senior staff presence across all our areas. And this is because of the pressures that we're experiencing on a daily basis. Particular focus has been on key dates across the 27th of December right through to the 3rd of January, when we know that our footfall to our emergency departments increases a lot. And I suppose the aim of this is to ensure that we have senior people who can make decisions for patients in terms of where they will flow over those days. You'll all be aware of our Site Coordination Hub, which runs now on a daily basis, and this will also continue to run with Assistant Director cover across Christmas and New Year. And depending on site pressures, additional Assistant Director will support, and a Director will be on call over that period. An extraordinary flow event is planned for the week beginning the 16th of December, with a complete focus on patient discharge, both from a simple perspective and for complex patients from both across acute sites. A further event then will be held the week beginning the 6th of January to ensure that we follow on from all the decisions made pre-Christmas and to prepare for the first quarter, as I talked about, mid-January onwards. The Regional Coordination Centre, which you'll all probably know now, is the coordinating centre which oversees the system of unscheduled care across the region, will continue to operate across every day over the holiday period, with the exception of Christmas Day. In our acute hospitals, our ambulatory services, our same-day emergency care, and our medical assessment units will remain operational, with staffing rosters linked to the GP opening hours, and our discharge lounge will remain open across the holiday period as well. In addition to this, we, I suppose, are resetting some of our flow operational processes on the Altnagalvin site, and that has already commenced at this minute in time, with the aim to establish any additional bed capacity that we can put in place before winter really hits us. We continue to develop our ambulatory pathways. We're looking at, I suppose, direct access for NIAS into our ambulatory areas and into same-day emergency care, and that is work in progress. And I suppose I just want to remind everyone today that there are alternatives to patients coming to ED for minor ailments, etc. We have minor injuries unit now at both our acute hospitals. We have our urgent care and treatment centre at Omagh, which continues to see an increase in the number of attendances on a daily basis. We also have a phone first service across the trust, that will direct patients to the right place for their ailment and their condition. And local pharmacies are also providing enhanced services for winter ailments and flu-like illnesses. So it's really important for patients who need to come to ED to continue to turn up in their emergency department. But for those that can be assessed, triaged and treated elsewhere, I think it's really important that they should use those alternatives to our emergency department. So thank you, Chair. That's the update, and I'll just move on to, sorry, yes, I want to just say something about the Southwest Acute Intensive Care Unit, once I have the opportunity. So there are no plans whatsoever to remove or downgrade the Southwest Acute Hospital ICU department. The ICU plays an integral role in providing intensive care bed capacity for our own hospitals and indeed for the region as part of the critical care network. It is part of a network of ICUs across Northern Ireland which deliver the highest quality of care to the sickest patients when they need it. We would respectfully request that those responsible for such reports to please refrain from circulating misinformation. Such misinformation is unhelpful and affects the morale of our staff who do such important work in Southwest Acute Intensive Care Unit, especially, I suppose, in our intensive care unit, but right across the hospital as a whole. And I'd like to maybe invite Dr. Monica Monaghan to make a comment on behalf of the staff at Southwest Acute, please. Thanks, Chair.
Thank you, Geraldine, and thank you for the invitation to the meeting. It's a pleasure to meet you all virtually. So as Mark indicated, I was present at the meeting on Thursday where there was representation from SPPG, and I sought clarity. Debbie very rightly said that communication is key, and nothing could be more true in the current climate of healthy healthcare scrutiny and transparency. And as a doctor on the ground that has made my home here, paying a mortgage here, and working with multidisciplinary staff, I sought clarity on the role of the ICU and the information that had been circulated in the media, and I received clear assurances to my satisfaction that there will be no change to the acute status of the Southwest Acute Hospital, the emergency department or the intensive care unit. And as Shirley indicated about morale among the public, so that too is reflected in the staff in the hospital. And I am able to reassure staff that their jobs are secure, and that those that have moved in a time and a climate where there are multiple opportunities, including cross-border opportunities for staff, that we do everything in our power, those of us that are in a position of influence and leadership, that the responsibility is on me and everyone to be as supportive as possible in getting a message of integrity. So I'm glad of the opportunity to share it here, and thank you, Geraldine.
Thank you, Monica. I'd like to now ask Valerie Devine to provide the committee this afternoon with an update on community capacity and discharge, please.
Thank you, Chair, for the opportunity to present the information in respect of the community. I'm Valerie Devine, Assistant Director of Community and Older People. And I suppose the focus of the information we want to provide today is really about how what we do in the community fits in with what a lot of the conversation is today. So that includes improving community capacity. So I talk about our rota optimisation, our early review team, the work that we're doing with our independent providers, but also begin to look at some of the things that enable hospital avoidance, look at our overview of our neighbourhood nursing and discharge to care homes. So if you could move that on. Thank you. So in terms of our home care, our domiciliary care, whichever you provide it, to many people, I suppose this is seen as a hidden service. And actually, it is the backbone of so much of the provision we provide, not just to our elderly population, but also to, our families with disabled members in their family as well. So, sorry, and there's some of the figures there in terms of, so I think, if you look at it, that as of today, if you look at how many service users we have in the day, but we've also got work on, because what we need to do and what we want to do is to make better use of our the capacity that we have in terms of increasing the contacts by optimising our rotas. And what in doing that work, so our work around rota optimisation, and when we talk about rota optimisation, we're talking about reorganising all of our rotas, all of our domiciliary care rotas within the Western Trust to get maximum capacity. The outcome of some of that work is that there's been 612 cases of unmet need accommodated. That's an increase of over 5,000 weekly hours. Also, there's no service user within rota optimisation who has experienced a reduction in time. Want to move that on, Chris, please? Thank you. So alongside that, we have our early review team, some of which is funded by SPPG and some of which we have now decided to fund from a trust perspective. And the early review team is a social work and occupational therapy based service with the aim, originally with the aim of reviewing every patient who was discharged from hospital with a package of care, because what we know is that quite often at the point of discharge, people have not reached their baseline, and it's still going to be a couple of weeks, and that once they do reach their baseline that they were at, there can be a reduction. You'll see some of what that has achieved in relation to the hours, but what we're also doing now, so particularly when we begin to look at, and when we look at the Oman Fermanagh area, there are a number of areas where it is very difficult for us to source provision for dom care, and that leads to extended delayed discharges in hospital. So we've now extended the role of our early review team, and we're targeting areas where there are patients who have been waiting for domiciliary care in hospital. So what we're focusing on, as well as the patients coming out of hospital, we're actually focusing on a number of those people who have had care for a long period of time, particularly if there's any local information or information from the social worker or from other professionals who are visiting, to say that perhaps there is scope to reduce packages of care to enable some of the unmet care or the unmet need to be met in those particularly hard to source areas. So I also want to talk a wee bit about our respiratory team, and our respiratory team is a community team, and it's trust-wide, and they manage people with respiratory illnesses. But what is also been happening is that there is a piece of work which is done in conjunction with our acute colleagues. And so it is both there's two aims of it. One is to avoid admission avoidance, and the second is to reduce the time that people are in hospital. And so what actually happens is that there is work that goes on so if someone presents to hospital in terms of trying to reduce their stay, what happens is there is a plan has come up, which is supervised and overseen by our acute colleagues, and that enables patients to go home early. And likewise, there are plans that are put in place to prevent admissions. So you'll see the data there, folks, and what is that there has been quality assurance around that data. So that's what that service has been able to do in terms of avoidance admission, but then also to facilitate early discharge. So there's a lot of information in this, folks, and in the interest of time, I'm not going to go through it all. What I will, I suppose, highlight is the developments in respect of co-produced care plans, which our clients are reporting that they're finding really helpful. There's also, in terms of some of our regional KPI indicators, particularly around the skin bundle and the MUST, those are regional KPIs, and our trust is one of the highest achieving trusts in respect of those. So some of our figures and our improvements, and that is very important. For the last box, I suppose the key point that I will put out is that 71 people through these services have been enabled to have end-of-life care at home. And one of the things that has added to that is that the trust is now commissioned, so Foyle Hospice is now a trust-wide service. So they now provide input in the southern sector in respect of that. So folks, when we begin to look at the hospital discharge process, what I've done is I put up here some data in respect of the number of people who've been discharged to care homes. Our core challenges from a hospital discharge, from a delayed discharge perspective, particularly in the southern sector, also in the northern sector, but much more so in the northern sector, is availability of domiciliary care in some of the more rural areas in particular. But then there is also nursing care and dementia beds within the southern sector. And I think similar to what has been discussed in respect of the GP practices, what our independent providers are reporting to us is that staff recruitment is one of the biggest challenges. And for our trust, and particularly in the rural areas, a lot of the providers that we have are small independent providers. They are not part of a larger group. Those providers that are part of a larger group are able to utilise international recruitment and other measures for recruitment that some of our smaller providers. We are engaged in an intensive piece of work around trying to increase the beds in the southern sector and that availability. And we're also providing some help for providers who are on the cusp of not being able to continue to do business. So we're working quite closely with them to ensure that that provision can continue. And folks, I really flew through that in the interest of time, but more than happy to take questions. Thank you, Chair, for the opportunity to present that information.
Thank you.
Okay, we'll leave questions until Dr. Monaghan has done the cardiac services update and Mark, the strategic development group. So maybe Monica, could you please do the next bit? Thanks.
Thank you, Geraldine. So just, I suppose, to give reassurance that cardiology in the southern sector, so based at the Southwest Acute Hospital, we have 3 consultant cardiologists, two of whom are substantive. One is a locum, and we have successfully recruited a third consultant cardiologist who will commence at the South West Acute Hospital as a substantive in 2025 when he finishes his fellowship in the Heart Hospital in Liverpool. We are open 24. We have two consultant cardiologists on call out of hours 24/7, 365, one of whom performs urgent primary stenting in the cath lab for patients that present with life-threatening heart attacks, and the other colleague works for general cardiology. Multiple access routes include the cardiac assessment unit in OMA, general practice, the emergency department, other trusts, nursing, heart failure service, etc. So we also currently in the South West Acute Hospital, we run 4 outpatient clinics, consultant-led outpatient clinics per week, a rapid access angina clinic, and multiple heart failure clinics. The cardiac assessment unit, the cardiac investigation unit is running in both the South West Acute Hospital and OMA Hospital, providing the entire spectrum of investigations to make diagnosis and management plans. And then we are at the South West Acute Hospital, a regional centre, one of 3 across Northern Ireland, where we provide cardiac MRI. And again, this is a regional service. We also we have 3 CT coronary angiogram lists across the South West Acute and OMA Hospital on a weekly basis, and this feeds directly from the rapid access angina clinic for patients that have chest pain, where we can directly now, without using the cath lab, reserving the cath lab for patients with heart attack, we can look directly at the coronary arteries by a CT scan, and that's in conjunction with our highly skilled radiographers and the entire team that work there. So as I say to all my patients, despite the busyness across the site, all the sites, the emergency departments, as was said by, I think it was Geraldine, we are open for business. We do need to see people if they are unwell, and they will be seen regardless of the pressures. Thank you.
Thank you, Monica. Just finally then, Mark.
Thank you, Geraldine. I hope you can hear me, Chair. So just an update from Strategic Development Group. SWA, South West Acute Strategic Development Group, remains focused on the stability and sustainability of existing services in South West Acute Hospital, and also to look at strategic developments and ideas that can be brought forward for the future to enhance services in the hospital. Stakeholders of that group include the Chair and CEO of Council, external community stakeholders, Department of Health, PHA, in addition to key senior stakeholders in South West Acute Hospital and the Western Trust, and the group is co-chaired by the Trust Chief Executive alongside one of the non-executive directors, the Reverend Judy McGaffin. In most recent discussions at South West Acute Strategic Development Group, it is important to point out that the Department of Health representatives, following the statement in the Assembly by the Health Minister with respect to the hospitals creating a network for better outcomes, document clearly stated that this is about reconfiguration of the network of acute hospitals and in no way affects the status of South West Acute Hospital. So it's really just to reiterate what Professor Monaghan said earlier. Thank you.
Thanks, Mark. That's us, Chair.
Okay, thank you for that. Before I go to the floor, I think it's important to take on board what has been said today. There's been a lot of misinformation out there, and certainly in a council meeting this month, we certainly became very aware of that. I think it's important that we as councillors issue the correct information to our constituents, so to reassure them, as there's a lot of untruths out there, and a lot of people are too keen to take false information from whatever means, whether it's media or whatever. But as has been said today, the acute services in SWA are at this moment in time have been assured, as has the ICU unit. So I think it's important that the public out there are familiar with that and are reassured with that. And, you know, as I said, it's important that we, as representatives on the ground, spread that positive information to our constituents. I'll now take questions, and the first person up in the chamber is Councillor Barton.
Thank you, Chair, and thank you everybody for your various inputs into the presentation this afternoon. I'm just going to make a few comments and maybe ask a question or so. Domiciliary care, it's nothing new that there's been a shortage of domiciliary care the past 10 years or so, ever from I became a public representative. So that's nothing new to us. But we heard in an earlier presentation in relation to the shortage of doctors, where perhaps recruitment could be improved in relation to GPs by offering incentives to the GPs. Now, I know I know they're paid differently, et cetera, from a different perspective, but is there no way domiciliary carers, they provide an invaluable service to the community, and is there no way that to recruit them, that perhaps their pay could be increased? I know they have had a pay increase, but look at providing incentives, especially you refer to certain areas where there was a particular shortage and where that held up people leaving hospital, et cetera. And I'm wondering, is there some way around trying to get more people to want to become domiciliary carers? That's the first thing I want to just make comment on and ask in relation to that. The second thing, in relation to discharge from hospital beds, I unfortunately had to have emergency surgery a year ago now for appendicitis, but I can say I received nothing, only the very best of care, and I had to be transferred from Enniskillen to Altnagalvin, but that wasn't the problem, except there was no ambulance available. But my husband brought me. However, that was by the by. But what I am saying, the time for discharge, I was told at 10 o'clock in the morning, you're ready for discharge. Not a problem. It was 6 o'clock that evening before I could get away. I was holding a bed for nearly a day because I couldn't get out of the ward because I hadn't got my discharge letter. Is there any way that procedure could be shortened? If you're told, I know it takes maybe an hour and a half for someone to come and collect one, but say within 3 hours, if you're told 10 o'clock in the morning, at least be away by lunchtime. And I'm wondering if that procedure could be looked into. And that's really all the comments I'll make. Yeah, thank you.
Okay, so I'll ask Valerie to take the first question around dom care and payments to their staff, but I'll take the discharge from hospital one, Councillor Barton. So I suppose it's something that we're very aware of, and we have a quality improvement project at this minute in time ongoing across both our sites in terms of early in the day discharge as part of the Safer Flow bundle work, and actually South West Acute is way ahead in terms of implementation. It is work around making sure the day before a patient is discharged, that their letter is ready. Nurses know in wards when a patient should be discharged, and I suppose their years of experience tell them such. So it's about bringing all that earlier into the journey. So getting the discharge letter ready. Unfortunately, the part of the discharge letter is the medications that are required for your discharge. So there's still a final check on the actual morning of discharge around all of that. So I accept that it is a long drawn out process in a number of wards, but we are very aware of it and we're making good improvements. We aim to have patients home before lunch. That is a target set for us across the trust, and we work hard to comply with that. We have a discharge lounge in Altnagalvin that patients go to. However, that doesn't mean they go any earlier in the day. It's just, it frees up the bed, which you referred to earlier. And I suppose the reason that South West Acute did not require a discharge lounge is because their early in the day discharge figures are higher than Altnagal. So take your comment on board, and happy to update you again at some point, Councillor, where we are with that project. So Valerie, just around the domiciliary care piece.
Yes, thank you, Councillor Burton. And I agree with you in terms of the core service that they provide. And I suppose there's a couple of things I would say. First is that within our Entrust Dom Care, all of our Dom Care staff have now been awarded a Band 3 upgrade, and that's actually been backdated for quite a bit of time. So we are actually looking to extend our in-house domiciliary care provision in the southern sector, because we are hoping that we're going to be able to attract some more workers now, because it is Band 3. And you're correct that there has been increases from a departmental level in respect of what is provided to Dom Care providers for each hour of Dom Care provision. We have highlighted through our regional meetings that I believe that there's work on which needs to be ongoing in respect of ensuring that all of those uplifts are actually passed on to the workers in terms of what they are paid per hour, and that's ongoing work.
Thank you for that. Just to say, are all domiciliary care workers paid same per hour, paid the same salary? For example, those that are recruited through various private procurement processes, are they paid the same? And if not, why not? Surely that would, if they could get a lift in salary too, if they're not paid the same, surely that should help your situation.
Unfortunately, independent providers set their own pay rate, Councillor Barton, so that's not something that we would have control over. However, we have been in our regional meetings highlighting that we believe that any further uplifts, that there needs to be some protection within that to ensure that all of the uplifts are passed on to the care workers.
So that really where the problem is.
Debbie?
Thank you, Chair. I want to make a couple of comments really regarding the domiciliary workers. Obviously they have been updated. I'm not upgraded in their pay. I'm not sure everybody's had their back pay this month, but anyway, it's all on the go, so that's good. But it's still, but you know, all domiciliary workers need the pay that reflects the importance of their job. And I've been one myself for years, a few years back, so I know what it's like. But one of the issues I have with them, and not them as workers, but the system, is that especially in our rural areas, I suppose the town as well, I'm a bit of a night bird, which is why I can work nights, no problem. And other people work until, you know, on their farms until maybe 10 or maybe even later at night. And then they get sick, and then they have a carer coming in. And I've come across so many people that have a carer coming in to put them to bed at 6 o'clock. And these people might have spent 60 years going to bed at 10 o'clock or 11 o'clock or even midnight. And now they're going to bed at 6 o'clock, and they may not be getting up till 9 o'clock the next morning. And this is a regular thing, especially in rural areas. And I'm wondering, you know I'm sure you have to pay. I don't even know if there is any night domiciliary workers. I haven't come across too many of them, but it's the patient's needs seems to kind of go out the window with domiciliary care, and that is not a criticism of the worker. I was in a house doing a form for a couple. The man is bedridden, and so I was chatting to his wife, and the two carers come in, and I would say in less than 10 minutes they were gone again. They'd checked his pad, he hadn't pooed, so away they went, and that was it. And she said that is what it is every day, and she would have done everything herself up until this point, that she's actually got sick recently now and she's not able to do it anymore. And I think the care that, especially in the private sector, you have to go in and quickly do your job, and quickly do this, and quickly do that, and quickly check your signature, and quickly do this, and quickly do that, and then quickly get to the next person. And the holistic care of the person isn't kind of taken into consideration at all. And that really worries me, because when I was doing it years ago, I was told off because I hung washing out in the garden, but the woman was blind. So I thought that was quite a sensible thing to do, to hang her washing out in the garden. And I carried on doing it anyway. I just didn't tell the boss at the time. But now you're not even able to make a cup of tea. It's very quick in, quick out, rush. So that's one thing I want to do. And I think just something needs to be done about that. And that's why people come into hospital. And so around the planning meetings that I had, are there any discussions around, say, for example, the opening of Ward 4 that could be used for non-acute patients that can't go home because they have no package of care? Is that an option, and bring carers into Ward 4 and have it as a kind of more of a resident place? I mean, it's there, it's got beds, it's got everything you need, and it's just lying there empty. Or somewhere like Drumclay opening again, or any other facility across our council area, because I can't remember the figure that was given at the beginning of the meeting now, but I work in the hospital, so I know there's plenty of patients, unfortunately, that don't need acute care, that could go home if they had a care package. And the care packages are just one of the major issues.
Can I bring you to a close, Debbie, please, because I've let you in there for 4 minutes.
No, hold on. Can I just ask one more thing, Chair? Just one more thing.
Okay, quickly, please.
Dr. Monaghan is the only one that actually touched on this, and this was the main thing I wanted to ask, was about the cross-border work and what is being done to secure our hospital, because unfortunately the stories that are going about and whatever is printed in the press, I don't buy the papers, so I don't know what's in there, but a lot of that comes from the Minister's report, Our Hospitals Are Better Together, where it quite clearly states that the SWA may become a general hospital. And I think a lot of them rumours, you're saying they're rumours, so hopefully that's what they are, but that's partly where some of that has come from as well. So to keep our hospital, whether it's a general or an acute hospital, but to keep it and to keep the services in there, what is being done, over recent times, especially since COVID, regarding cross-border cooperation, collaboration, please. Thanks, Chair.
Okay, so just before Valerie again comes back around the dom care piece, just in terms of Ward 4, I absolutely accept the ward is sitting there, but the issue for us would be in terms of the feasibility of opening that ward, councillor, in terms of workforce. So the nursing staff, the medical cover, albeit may not be a huge need, but we still would have to have sufficient cover to ensure patient safety. However, I will take it back to our corporate management team in terms of how we might do that. Cross-border work, we are obviously a high priority for this trust is the cross-border part of our work. We have had recent conversations with the Minister actually on a visit about how the current services that we provide and how we might expand that. And so actually he's waiting on the outcome of the election in ROI over the next number of days to try and engage with the Minister for Health down there, whoever that will be, I suppose, in terms of work on that. We have had a number of visits as a trust from cross-border facilities, the Department of Health, CELTA, which is the one of the trusts, right, just in terms of North Donegal and down the border corridor. So we do communicate regularly, but at this stage there's nothing planned in terms of expanding that work. I can't remember your third. Yeah, the reconfiguration document that you talked about. I suppose I can only state again, Debbie, that there will be no change to the status of Southwest Acute Hospital at this time. And I think we have all been very vigorous in our statement of that today. So Val, I don't know if you need to comment any more on the Dom Care piece, Valerie. Thanks.
Thank you, Geraldine. I think just a couple of comments. First is in respect of the bedtimes. We really aim not to have 6 o'clock bedtimes, and where we do have to put them in, we aim but unfortunately, the reality is that almost everyone wants a bedtime at the same time, and we don't have the carers to put everybody to bed at the same time. So what we do is we try and then we create a waiting list. But I certainly will feed those comments back to my colleague, who's the Assistant Director for Dom Care. Especially, I'll feed back in respect of your comments with regards to, some of those social tasks. But I do know that one of the things that you would say is that the level of unmet need, you're always balancing the level of unmet need and where people don't have any carers with how much time then you can provide for certain tasks for other carers. But I'm more than happy to provide that data. Chair, I have to give my sincere apologies. I'm to travel to a meeting now and I'm already running late. So if there was something else urgent, again, sincere apologies. I had it in until 4:30, but I do have another meeting at 5 and have to travel to it. So
Anne-Marie, we'll take you in to see is your question in relation to domiciliary.
No, I'm happy enough with domiciliary, just as Debbie had said, just as the rush in and rush out, and people hate that. The workers hate that. They're not giving the best they can. It's forever, you know what I mean? I don't mean this derogatory, but you know what I mean? It's a quick move, you know what I mean? You don't pull, you don't push, you don't shove, but please don't talk to me. Get in and out, get in and out. The last wee lady fell and behind him, he wrote out, you know what I mean? I'm waiting in an ambulance, you know what I mean? Somebody blocked me in. It's just a whole hand. So that's why recruitment isn't one way out, you know what I mean? Yeah, it really isn't. But I'm happy enough, Barry, let you go on ahead. I don't have any other questions. But thank you very much and safe journey if you're away, heading away. A few other things. Sorry, go on ahead, Barry, go on ahead.
Once again, thank you for the opportunity. Thank you.
Thanks, Valerie.
Thank you. Yes, just going forward, I have a few things down there and I'm sort of sad that Mark's away, but it's great to see that there's been a lot of work with this strategic partnership going forward with the SWAB, especially with the minor surgery. And I just wanted to know exactly what the minor surgery would have been, maybe appendectomies or something like that there. You mean something which is as minor as that, or maybe they don't count that as minors, or testicle torsions or something like that. So that was all that I want. It's good to see that the head injuries, large number of head injuries come back from patients who are on blood thinners and that. So it's good to see that they will hopefully be assessed down in a scan and be able to have a very good practical move, And even for those there elderly ones that don't want that double travelling up to Alton Galvin. One of the things that I was wanting to state as well about that the Omagh hospital transfers. I know that there's quite in ones, but there is ones that sort of do slip across, and it's to do in a scale on Southwest Acute Hospital. I know that if they have a hip fracture, Omagh urgent care doesn't really get them, but if they do get something of that nature, they're able to give morphine, they're able to give IV paracetamol, they're able to look after the patient's care needs. But there is occasions of where they do transfer down to Alton Galvin A&E, so that's doing a transfer from a bed onto a trolley, and then from our trolley onto the bed in A&E, and then that's holding it up in there. So just wondering why there can't be the same sort of setup from Omagh urgent care, especially when there is qualified nursing staff there all the time. You know what I mean? And so I thought that was maybe something that the trust could look forward. Is that there? It's as much for the lack of movement for the patient, but also from the ambulance service as well. You know what I mean? Having to queue down that in the Galvin, waiting on a bed down there when something could cover from Oma. One of my gripes as well, well, it's not really a gripe, come here, but it's just to do with A&E and ALT and the thoroughfare going up and down that corridor, the back doors from emergency departments. It's crazy. It's crazy. You have people going on and out for fags, you know, people standing around the corners for conversations. It's just in and out, you know what I mean? And it's a thoroughfare, and it doesn't happen in any other hospitals. You don't get it in the Royal, you don't get it in Antrim Hospital. As you know yourselves, a large volume of patients up and down the corridors, a lot of them elderly, nightwear, just one blanket over the top of them, and that door is constant going up and down, please. Is there a way of getting that off access? I know there's a sign there, no public access. One of the ambulance crews did say to somebody, sorry, but you know, you're not allowed in, and she got a mouthful, so she just backed off. Can that not be covered off, the glass etched some way, that there's a coding system at the front, like there is in the Royal and Antrim? That was just one piece of work from that there. Great to see the patients is administering insulin and Plaxine at home. Very good practical things, you know what I mean, and wasted an awful lot of time from district nurses. Although I know families are very reluctant to do it, it's very easy to do. I was in my shift one night or one morning, and there was a district nurse there just to do that simple task, and I just thought, oh God, that. Whilst they were a lovely family, but there was people there who was able to do it. Maybe they weren't asked. And cardiology is an amazing facility. You know what I mean? We have a very good trust, and I hate to see when people do sort of berate everybody in the press. But you know, politics and Trumpism and stories is very good and very easy to get the public riled up. But you know what? I'm proud of what we have, and I'm proud of everybody who works there, because it's an amazing facility from everybody down. You know, I really, really do. I appreciate everything that everybody does. So it's just those general wee tidy up things, you know, that can be done. And and I think that's 71 people supported today at home, trust-wide. I think that's a very, very good initiative. You know what I mean? So just be picky things, but you know what? I think we have a brilliant health service. We really, really have. And there's things, of course, that we can't add, but sure, there's people who are doing it for everybody else. And that was it. Out the Galvin doors is a real irk for us.
Okay, thank you, Anne-Marie. I suppose there's a couple of things for me. We can get Mark to send you the list of procedures that have been agreed in terms of the operating procedure for SPA that can happen there, so we can share that, Chair. I'm happy to get him to do that. In terms of the Oma Hospital transfers, I suppose this is part of our winter discussions and winter planning, as well as everything else. I think there's a lot more, I agree with you, that could happen and could be done. Councillor, so I will pick that up outside again with NIAS in our conversations. The ED out in the Galvin thoroughfare, it annoys me too, and I'll just be really clear about it. It's open to the public. It's the main entrance and exit after 9 o'clock at night, and we are working to see how we can do that. That is a work in progress, Councillor Fitzgerald, just to let you know that. And I suppose it is important that I say we have been asked, and you're all aware of this anyway, to submit an outline business case for our new ED department at Altnagalvin, and all those measures hopefully will be resolved when we do that. So thank you.
Thank you very much. I appreciate it. And I think that Oma Urgent Care really has the bed capacity. They say they don't, but my view they have, but that's it. I'm going back out now before I get myself in the bother. Thank you.
Okay, thank you. We'll move on to item number 7, which is members' queries. There might have been some of these already covered, so I'll pass over to Geraldine again.
Okay, so the first one there is the update on the business case for the proposed mental health unit. So we have a comprehensive update today from Karen O'Brien, the Director for Mental Health. We will share that in the e-brief in the interest of time, Chair, if that's okay. And Karen has agreed to come back in February to give a full presentation on mental health services to the committee at the February meeting. If everyone's content with that, we have a written update for today. The ring fence beds for the transfers, Mark has covered that in his presentation, and he gave you the most recent data. Do you want me to go on down these? Chair, the rest raised at full council meeting, update on recruitment. Dr. Monaghan has done that, I suppose. And there's a number 4 there, an update on the staffing levels and changes to the appointment booking system at the treatment room in Omagh. I'm happy to read out the update if you wish, or we can put it in the written brief as well.
If there's quite a bit to it, put it in the written brief.
Okay, thank you. Can do that, and I think that's them all, unless I missed something there.
No, I don't think you have. Okay.
Just want to ask one question. It'll be short. The A32 road between Omagh and Enniskillen. What pressure are the SWA putting on road service or DFI to try and get that road? Knew there were to be 9 schemes originally. 10 years ago, there were 9 schemes identified on it to have it upgraded. 3 of these have been complete. We spoke to Road Service as a council there a month ago. They don't have money to complete, to look at some of the rest and complete it. I know there's one shovel ready at the moment and they're waiting on finance to do that. And I'm wondering what, it would also help the Southwest Acute in relation to transfer times and for very, very ill patients. Some of them sometimes have to be transferred from Omagh to Enniskillen for scans, and that road in an ambulance, they are already very fragile ill patients, and that road in an ambulance is certainly not a very pleasurable journey for them. It's bumpity. So I just ask, you don't have to give me an answer today, but can you?
I'm not in a position to, Councillor Barton, because I'm not sure if there's been any influence from the Trust.
I think
as an organisation, we're in the business of, I suppose, providing healthcare to those that need it at the point of delivery. So I'm happy to take it away and come back if need be, but I'm not sure, Chris, if there's anything we can do. But I'll ask anyway, Councillor. Thank you.
Thank you.
No problem.
Okay.
So, Chair, I wonder, could I maybe, it's just if I could comment on that last item for Councillor Barton's benefit, maybe just, and I appreciate it was prior to Councillor Barton's return, but the Western Trust has written to support the council in our lobbying efforts regarding the road. Unfortunately, the road was not included in the upgrades to the road. The A32 were not included in the original business case and decision making, and there is no mechanism for those to be introduced retrospectively. But we have formally had correspondence from the Trust that has accompanied our submissions into the department regarding the A32.
Okay, thank you for that update. Next on the agenda is item number 8, to receive an update on the SWA Strategic Development Group. Sorry. Well, I think that has come to the end of that part. We have one item of correspondence. Just like to thank the Trust for coming along today. A lot of us feel that these meetings are very important for giving us information. And again, I would like to stress what has already been said, that the negativity surrounding our own hospital, the SWA, and that's obviously, I'm being a bit biased here because I'm Fermanagh based, but we are very lucky to have it. And I think the negativity that surrounds it is sad, and we need to be more positive. We need to leave here positive today, and on the information that we've been told that there is no plans to change any of the current situations in SWA from being an acute hospital and the ICU. So I think it's important that that goes out there, that everybody's clear on that. So if you want to leave now, or you're welcome to stay, thank you very much for coming along. Next, we'll go on to correspondence, and that is to receive a letter from Oak Healthy Living, and there is a copy attached. Alison, is it?
Yeah, thank you, Chair. Chair, members will have seen the letter that's been received from Oak Healthy Living, and really it's in relation to the social value potential of the Future Works contract at Lisnaskea Health Centre. While it is forwarded to us, it is really something that the council won't have any role in terms of the procurement. So I would suggest maybe, Chair, that we would note the correspondence, and then we could certainly write. I'm assuming members would be supportive of any local community benefits and tie in with, for example, Oak Healthy Living Centre in relation to the contract, but we wouldn't have any decision-making role in that regard.
Okay, thank you. So can I have a proposal to note that? Councillor Barton, and a seconder I'll have to take from online. Somebody put their hand up, please. Councillor Fitzgerald, there's a whole lot of hands going up there. Thank you. So that's noted. Basically, any urgent or relevant business have not been informed of anything today. And next is the dates of the next meetings to be agreed. The only thing I would say about the meetings, 3 o'clock, is there any possibility of pulling them forward in there? Because 3 o'clock obviously left the trust staff pushed there today. So I don't see any reason why we can't bring them forward too.
That'd be appreciated, Chair.
Yeah, Chair, we can certainly follow up with the trust. I think originally a couple of members on our side had indicated a preference for 3 p.m. start, but if members are content, we can work on the basis of 2 o'clock and we'll liaise accordingly with the trust.
I think that would be good, because at the end of the day, if you look at their attendance today, that is obviously regardless of what time the meeting was at, it certainly is in the chamber here. There's 2 of us, and the rest online, which is fine. But there's a lot of empty spaces today. So okay. So the dates are in front of us there. I suppose February isn't that far away. So is everybody happy with those dates in front? And we'll look at the time of bringing it forward, possibly to 2 p.m. as opposed to 3. Everybody happy?
Yeah.
Yeah. Thank you. Okay. Thank you, everybody, for their attendance today, and we'll happy Christmas to you all. I'll see some of you before that again, but so we will move on. Thank you, everybody.
Okay, Chair, thanks a lot. Happy Christmas, we'll see you soon.
Thank you, Chair. Thanks.